Right, for day 11, we had a bit of a shorter video yesterday, but for day 11, back to the chunkier videos. Today, I want you to go through calculations pack 5, which includes 10 GPhC style calculation questions. The MicroPharm quiz night, which includes GPhC style clinical questions, and the entire infection sepsis module, which is as below for members. For non-members, I'm going to include 2 parts of the sepsis series, and I'm going to include the recording for the MicroPharm quiz night. So in total, 10 calculation questions, the MicroPharm quiz night with clinical questions, and the entire sepsis. Understand the entire sepsis module, or go through sepsis thoroughly if you're a non-member. Okay, I will stop the recording now and we'll get started with the sepsis videos and then finish off with the quiz night. My name is Yasser, and today is the first part of the lecture series on sepsis. So what we know about sepsis is rapidly changing over the years. There's evidence to show that the manifestations of sepsis can no longer be attributed to the infection and just the immune response. But there's also alterations in coagulation, immunosuppression, and organ dysfunction. So we're going to split this lecture into 5 parts. The first part, I'm going to introduce sepsis and the history of sepsis. The second part, we'll be speaking about the pathophysiology of sepsis and what essentially happens when a patient has sepsis. The third part, we'll be focusing on the patient assessment. So how do we assess and categorize patients that are higher risk of having sepsis? And then in the fourth part, we'll speak about red flag sepsis and amber flag criteria. And in the fifth part, we'll speak about the management of sepsis. So what is sepsis? Sepsis is a medical emergency, and it describes the body's systemic immunological response to an infectious process. And this response can lead to end-stage organ dysfunction and eventually death. Every 3 seconds, someone in the world dies of sepsis. Globally, sepsis claims 11 million lives a year. And in the UK alone, 250,000 people are affected by sepsis. And of this, 50,000 people lose their lives in sepsis-related illnesses every year. The reason why these figures are so concerning is the fact that if a patient is diagnosed early, they can be treated very easily. So there's quite a few different definitions of sepsis, and the reality is none of the current definitions are perfect. But we're working towards that as we start to understand sepsis better. So we'll speak of the Marinoff-Ley definition. This is a general definition that you will often hear of. Sepsis is a life-threatening condition, and it arises when the body's response to an infection starts to injure its own tissues and organs. And one thing that's very important to note here is that it's the body's response to an infection, not the infection in particular. And why that's very important is 2 patients can be admitted into hospital with pneumonia, and one will develop sepsis and one person won't. And even though they categorically have the same severity of an infection, some patients' bodies respond in such a way that they start to damage their own tissues and organs. And we don't truly understand why that happens yet. Now let's speak about the professional narrative definition. And this is that sepsis is characterized by a life-threatening organ dysfunction due to a dysregulated host response to the infection. So a little bit more detail about what happens in sepsis, and we'll speak about this dysregulated host response and essentially what happens in sepsis in the second part of this lecture. And the third definition that I thought is particularly important, and that's why I put it here, is the definition of septic shock. Septic shock is a subset of sepsis, so it falls within that broad category of sepsis. And this is when there's profound circulatory, cellular, and metabolic abnormalities. And this would substantially increase your mortality. And the reason why septic shock is important is if a patient is diagnosed with septic shock, 50% of these patients die within 1 month. And that's why they have to be treated in a much more urgent fashion. So let's break down this term, septic shock. The term septic is a Latin word for rotten. And the term shock means decreased tissue oxygenation and low blood pressure. Combine these two terms together, it means that it's decreased tissue oxygenation caused by something that's rotten. And this term rotten is due to infective material. And this infective material can be either bacteria, fungi, or it could be a viral cause. So really, it's the fact that your tissues are not getting enough oxygen as a result of something that's either in your blood or within your tissues. So in 1991, there was a conference, and this was led by a man called Roger Bone. And this was the first time they introduced the definition of sepsis. And what the term they used was systemic inflammatory response syndrome, SIRS. Originally, there were 4 criteria that were proposed, and any patient that meets 2 of these criteria is assumed to have systemic inflammatory response syndrome. And the criteria was later developed into a wider set of criteria, numbering 12, but this will be too difficult to calculate along the bedside. And that's why this was decreased to 6. And the current criteria is 6, but we no longer use it in practice. Why do we mention SIRS if it's no longer used in practice? There are 2 reasons for this. The first reason is that it's still relevant in identifying infection. And the second reason is that due to if there's a presence of 2 of this criteria, it can be used to define uncomplicated sepsis. And uncomplicated sepsis means that there's no evidence of organ dysfunction. And then we've got the QSOFA. QSOFA is used and it aids the identification of patients with a high risk who have a high mortality. It's relevant when there's no track and trigger scoring systems, and we're going to speak about track and trigger scoring systems in the next slide. And it can identify the risk of a patient deteriorating. It has received some criticism to say that it's highly predictive of a poor outcome. That's correct, but in some of these patients, it may be too late, and patients may be too close to that mortality risk. So it can predict that there's a poor outcome, but it's very late in allowing the clinician to do something about it. QSOFA is considered positive if a patient has 2 or more of these clinical criteria, of the 3 clinical criteria here on the slide. And that's a respiratory rate of 22 or greater per minute, altered mental state, and this is calculated by a Glasgow Coma scale of less than 15, or if a patient has systolic blood pressure less than 100 millimeters per mercury or less. So now let's talk about the track and trigger scoring systems. So the current track and trigger scoring system we use is the National Early Warning Score 2. And this was introduced in the late 2017 by the Royal College of Physicians. It's a highly validated tool in identifying anyone with a deterioration risk. And it outperformed the modified early warning score as well as QSOFA in predicting the adverse outcome in patients with an infection. And that's why the large majority of trusts will use the NEWS2 chart. And you may have seen patients being assessed in accordance with the NEWS2 chart when you had your ward visits within the first year. Now, the consensus is, with the UK Sepsis Trust as well as NICE, is that anyone with a score of 5 or more should be screened for sepsis. Now, this doesn't mean that anyone who has a score of 4, for example, but looks clinically unwell, should not be screened for sepsis. And clinicians are often empowered that if they feel a patient is very clinically unwell, has the signs for sepsis, but doesn't meet that criteria of 5, should still be screened for sepsis. So let's talk about NEWS2 in a little bit more detail. So the National Early Warning Score is based on a simple scoring system that gives you a score allocated for different physiological measures. For example, the respiratory rate, the oxygen saturation, systolic blood pressure, and you can remember in QSOFA we also looked at systolic blood pressure, pulse rate, the level of consciousness or new confusion. Again, this is very similar to QSOFA. and the temperature of a patient. And all of these 6 values gives you a score. If a patient has a score of 5 or above, they should be screened for sepsis. In essence, the higher the value, the greater the response. So the greater your response should be to these patients and managing these patients. This concludes the first part of the series. In the next part, we'll be speaking about the pathophysiology of sepsis. So welcome to the second part of the sepsis lecture. In this part, we're going to be going through the pathophysiology of sepsis. We want to know why it occurs. So I did say to you previously that you could get 2 patients that are admitted into hospital, both, for example, with community-acquired pneumonia. One of the patients will develop sepsis and one won't. And we don't fully understand why this occurs. Some of the factors that could play a role in this include the type of pathogen that's causing the infection. Some are more virulent than others. Also, the number of pathogens that are present and where they are located in the body. And then we consider the individual's factors or the host factors. And this is determined by the patient's genetics as well as any other conditions that predispose them to infections or to this dysregulated host response. So we're going to go through the pathophysiology of sepsis as well as septic shock. We spoke about previously septic shock being a subset of sepsis and a severe form. And we did break down the origin of the word. But I'll break this down again. Septic is a Latin word for rotten, and shock is a term we used that medically means there's a decreased tissue oxygenation and low blood pressure. And we're going to speak about why both of these occur. If you combine septic shock together, this means that there's decreased tissue oxygenation caused by something that's rotten. Rotten here means infective material that can then lead to this decreased tissue oxygenation. So, blood is normally used to deliver oxygen to tissue cells, and they do this by using red blood cells. And red blood cells have the ability to deliver oxygen to these tissue cells, but once there's infective material in the bloodstream, and this could be in the form of a bacteria, virus, or a fungi, white blood cells, which are a part of your immune response, start to arrive in the area and start to encounter this infective material. And they realize that this is not supposed to be here. Blood is usually a sterile environment, and therefore infected material or unclean, rotten material within the blood cells makes this environment no longer a sterile environment. And if you link this back to the word of septic, we said septic is Latin for rotten, and this is where we have this rotten material, this infective material within the blood cells. And white blood cells arrive in the area, and they want to clean that environment and remove this unclean, rotten material. And in order to do this, they need backup. So they call for backup. And this is the first step in that response. And therefore, we have the first step is white blood cell recruitment. Now, if the infected material is not in the bloodstream and is in the tissue fluid, which is outside of the blood vessels, which is what is happening in the large majority of the time, white blood cells need to move from the blood to the interstitial tissue that's surrounding or across the lining of the blood vessels. So here you can see this thick lining of the blood vessels, and they need to get across that. The way they do this is they release different molecules. One of the molecules that they release is called nitrous oxide, and this interacts with the blood vessels. And once it interacts with the blood vessels, it causes blood vessel dilation. And the term we use for this is vasodilation. In other words, they decrease the diameter of the blood vessel. So if you look at the picture on the left and you look at the picture on the right, this is an example of vasodilation. So we've increased the diameter of the blood vessel. And what this does is it decreases vascular resistance. if you're thinking about all these red blood cells traveling through your blood vessel, if you're now making that, essentially that road, a larger road, so imagine it being a motorway, you've now created 6 lanes in this motorway, there's going to be less traffic. So now you've decreased vascular resistance, and therefore you've decreased systemic vascular resistance. There's an equation that determines your blood pressure, and it's cardiac output multiplied by systemic vascular resistance equals blood pressure. If you decrease the systemic vascular resistance, you are in turn decreasing blood pressure. And I want you to remember this. So the blood now has more space to move around, and it's not bumping into many things as much as it used to because of this increased space. So you've got a decrease in resistance and also a decrease in blood pressure. So this means that your blood starts to slow down. This increase of resistance increases the flow of your blood. So less resistance means that your blood's slowing down, and at the same time, white blood cells also need to make your blood vessels leaky in order to improve their permeability to get through the blood vessels. So they do this by using nitrous oxide again. And this leads to this term shock, where you've got an increase in permeability of the blood vessels, you've got a decrease in vascular resistance, and you're reducing blood pressure. And like we said to you before, the term shock means that there's decreased tissue oxygenation and low blood pressure. Now, I haven't really spoke about why there's a decrease in tissue oxygenation. Why is it more difficult for oxygen to get into your tissue cells, which are surrounding your blood vessels? And the reason for this is once you've got this leakiness, where you've got these holes in the blood vessels, you've now allowed fluid to make its way from the blood vessels into that extracellular space. So you've now allowed it to get into this space outside of the blood vessels, and this fluid comes in the way from your oxygen coming from your red blood cells into the tissue cells. So this fluid is now getting in the way, and it's essentially starving your tissue cells from oxygen. And this leads to tissue cells, with these tissue cells being starved of oxygen, this is the primary cause of shock. Now, white blood cells also want to destroy this infective material, and they do this by releasing reactive oxygen species and these lytic enzymes in order to damage and destroy the pathogen. And what I'm going to stress to you is this is happening everywhere around all the blood vessels in the body. So you're not only damaging the pathogen here, but you're starting to damage the blood vessels too. And this is a widespread response occurring all over the body, and this can lead to serious complications. Now, as blood cells are being damaged, coagulation factors are coming into play now, and they're arriving in the area in order to patch up the damage that's being made by the white blood cells. So in order for coagulation to occur, you've also got these coagulation factors, and they're proteins that help with clotting. So when blood vessels are ruptured, you want to create a clot to patch up that area so that blood doesn't move from the vessel into that extravascular space. Now, like I said to you before, this is happening all around the body, and your coagulation factors are now getting used up, and you're completely depleting the stores here. So coagulation can't keep up with the breakage of these blood vessels, and now you've got these small blood clots that are continuously trying to be formed, and they're breaking off, and you end up in a state where coagulation factors are completely depleted, and they can't keep up with the ruptured blood vessels. The name for this state is disseminated intravascular coagulation, DIC, and it's a very serious complication because your body can no longer keep up with the damage that's occurring, and can no longer keep up with the coagulation that's required. Another complication that can be seen in septic shock is acute respiratory distress syndrome, also known as ARDS, ARDS. And now we're going to move to the lungs. So the lungs also have a large amount of blood vessels in their area. And this means there's a lot of blood vessels that are required to take oxygen from the atmosphere and take it towards the heart in order to move that oxygenated blood towards your entire body. So I said to you before, blood vessels are being damaged all over the body. So these lytic enzymes, cytokines, all other sort of immune molecules end up damaging blood vessels in the lungs, and therefore oxygen can't be properly absorbed from the lungs. And this leads to patients moving to a severe septic shock and end up in respiratory distress. So like I said to you before, septic shock means that you've got decreased tissue oxygenation. If you have an inability to get oxygen from your lungs and move that oxygen around your body, you've got a massive decrease in tissue perfusion, so oxygen making its way to your tissue cells, and this leads to respiratory distress. Again, this is a severe complication. So the two complications that we've addressed now are disseminated intravascular coagulation as well as acute respiratory distress syndrome. And finally, we've got an increase in cardiac output. So cardiac output starts to initially increase as a result of your decreased vascular resistance to try and balance that equation. However, as a patient starts experiencing septic shock, the heart starts to become damaged by the immune molecules as well. And if you leave that untreated long enough, cardiac output then begins to decrease as well. And this would further decrease your blood pressure. So a major symptom of a patient with septic shock is the fact that their skin will be warm. And this is because you've got this widespread vasodilation that's occurring because of nitrous oxide. So the central nervous system is trying to increase blood pressure and cause vasoconstriction. And this is in response to this vasodilation that's occurring throughout the body. If vasoconstriction occurs because of the central nervous system, then your skin starts to become cooler and your blood vessels will start to become less leaky. And this will lead to an increase in your heart rate in order to compensate for this. So this is known as compensatory tachycardia. And the body attempts to compensate for the fact that you've got low blood pressure. So at the same time, your circulating volume is starting to become depleted. So the amount of blood that you've got circulating back to the body starts to become depleted, and the compensatory mechanisms start to get exhausted. Circulation begins to fail at this point, and the patient starts to look a lot worse with cool skin. So if a patient has cool skin, this is a sign that they may have prolonged capillary refill time, and this is a sign of possible organ dysfunction. And it's critical to ensure that you identify patients that are at this stage and they move into critical care immediately, because it means they're no longer at a state of vasodilation across the entire body, but they're now in a state of vasoconstriction, which is happening to compensate for the initial vasodilation. So they're at a very late stage in the sepsis pathophysiology. So this completes the section on sepsis pathophysiology. And in the next section, we're going to start to talk about the patient assessment. Yeah. So in terms of single best answer questions, more than one answer could be correct, but there's one that would be more likely than the other. Then you've got 30 extended matching questions. And we will be going through, in later webinars, we'll be going through examples of extended matching questions. For part 1, you've got 2 hours to complete part 1. And for part 2, you've got 2.5 hours to complete the paper. A calculator is permitted for paper 1, but it's not permitted for paper 2. But you can still have calculations in paper 2, but those are expected to be worked out without a calculator. In terms of high weighting material, this makes 60 to 70% of the paper. And these percentages is the way I often tell trainee pharmacists to organize their revision in accordance with what percentage weighting there is. So you should be spending 60 to 70% of your time looking at high weighting material. Which topics, which therapeutic areas are high weighting? Infection, cardiovascular system, endocrine system, and CNS. Absolutely. And the medium weighting material, can someone tell me what the medium weighting topics are? GI, respiratory system, genitourinary system, blood and nutrition, if anyone has mentioned it, immune system, and malignant disease as well. And then the low weighting material makes up to 10% of the questions. There's one thing that's very important that the GPhC stipulate, and that the patient scenarios could involve patients with conditions that involve more than one therapeutic area. But the question itself may be relating to one therapeutic area. And that's because patients don't come in and say, I've only got diabetes. Patients have diabetes and possibly heart failure alongside that. So they have to make those questions realistic. And there's an opportunity so there's a giveaway for today's session. All you have to do is take a snap from today's session and tag MicroPharm on Instagram. And this is from any portion of the session, and the winner will be announced on Instagram. Okay, so let's start with how prepared people feel at this stage. Okay, most people saying either not prepared at all or slightly prepared. Not prepared at all is always an overstatement. And the reason why I say that is from the over 6 months that you've spent in practice so far, you're going to pick up a lot of things. From your undergraduate studies, you're going to pick up a lot of things. So not prepared at all is always people are being harsher on themselves than they should. But being slightly prepared is probably where a lot of people are. So I'll share the results. So you can see 40% of people are saying they're not prepared at all. If you've just officially started your revision, this is a good time to start. It's not a bad time to start. If people are telling you you won't be able to do it, not true. You can. This is about the time this is about the month that it was crunch time for myself when I sat the assessment. Okay, let's get started with questions. So Mr. Allen is a 25-year-old patient, presents to the A&E department with a dog bite, assessed, and the decision has been made to prescribe antibiotics. No medical allergies, which of the following would be the first line treatment? Okay, I'm just going to wait for a few more seconds for people to answer before I share the responses. 70% of people have answered so far. By the way, all of these are all your answers are anonymous. So give it a guess. I can't see any answers. Okay. So my first question is, if this was a case of cellulitis and not a dog bite, what would the treatment option be? It doesn't have to be from these options. Just let me know in the chat. Flucloxacillin. But because it is a dog bite, what is it going to be? Coamoxiclav. Why is it going to be coamoxiclav with a dog bite and not cellulitis? It's broader in terms of its spectrum of activity. And I believe from one of the infection sessions, I've probably asked this question before. What is it about coamoxiclav that makes it more useful? Provides anaerobic coverage, absolutely. So if this patient has a penicillin allergy, what would be the treatment option for them? Metronidazole and doxycycline. So the metronidazole provides you a broad spectrum of coverage, and then the doxycycline. Sorry, I don't know if I said it the other way around. The doxycycline provides you a broad spectrum of coverage, and the metronidazole provides you your anaerobic coverage. So if you're going for an antibiotic that doesn't provide you anaerobic coverage, then it's very important to add that anaerobic coverage in by adding in metronidazole. The correct answer for this patient was the coamoxiclav because it's broad spectrum but also provides anaerobic coverage. That is important because there's anaerobic organisms in the mouth of the animal, in the mouth of the dog. And quite often you will find Bacteria fragilis in the mouth of the animal. And that's not covered if you give this patient flucloxacillin, and that's the risk. So when it comes to skin infections, there are two most common ways in which the bacteria can cause an infection. That's penetration of the skin, so there's some form of piercing of the skin, or overgrowth on the skin. And if you've got a dog bite, you've got that piercing of the skin, and therefore the skin barrier is compromised. So that's a way in which you're worried about the bacteria in the dog's mouth getting in. Mrs. Washington is a 74-year-old patient, called the community pharmacy. She's noticed that she's extremely shaky and sweaty since starting a new medication. Which of the following medications is likely to be responsible for her symptoms? Okay, just give it a, I'll give it about 30 seconds. We're on 60% of people have answered so far. Okay, I'm going to share the answers. What do you think is happening with Mrs. Washington? These are symptoms of hypoglycemia. The sweating and the shaking are typical features of hypoglycemia. So it looks like it's related to an anti-diabetic medication that can cause hypoglycemia. So which agents are anti-diabetic from your options here? your metformin or your gliclazide. So it's A and B. What is C? A thiazide-like diuretic. D. What is D? And A or B, absolutely. So from your options, A and B are your anti-diabetic options. Why is it B and not A? A doesn't cause hypoglycemia, and why doesn't it cause hypoglycemia? Absolutely. Its purpose, the way it works, is it does not stimulate insulin secretion, and gliclazide does. So therefore, gliclazide is more likely to cause the hypoglycemia, and therefore gliclazide is the correct answer. Okay. Mr. Adams walks into your pharmacy and complains of his new inhaler. That's led to some soreness in his mouth, and he's noticed white patches on his tongue. Which of the following inhalers is likely to be responsible for his symptoms? Okay, let's go through this answer. So this question, I'm being harsher than the GPhC. That's the first thing I want to make very clear. The GPhC would actually provide you the active ingredients for the inhaler. So they will provide you the brand name and the active ingredients in the inhaler. But I thought let's just test you even further. So let's use this as an opportunity for it to be harder, so it's easier for you for the exam. So what does Foster contain? Beclomethasone and formoterol. And the beclomethasone is an inhaled oral corticosteroid. What does Ventolin Evohaler contain? It contains salbutamol, which is an example of a SABA, a short-acting beta receptor agonist. And Ceravent Evohaler contains what? Salmeterol. Yes, it's an example of a long-acting beta receptor agonist. And the tiotropium is contained in the Spiriva, and the Atrovent, you've got what? Ipratropium. So tiotropium is an example of what? A long-acting muscarinic antagonist, and the ipratropium is an example of a short-acting muscarinic antagonist. So what do you think these white patches are? The signs of oral thrush or oral candidiasis, and the treatment before the treatment, the cause of oral thrush is there's a risk associated with using inhaled oral corticosteroids um, because they can cause oral thrush, and therefore the only option and the only inhaler that contains oral corticosteroid from these options is Foster in the form of beclomethasone, and therefore the correct answer is A, Foster. Now, in terms of the question itself, is there anything that you could advise the patient to do to prevent them from experiencing oral thrush? Yep, there are two things. Rinsing the mouth after use of the inhaler, and also you can advise patients, particularly if this is a risk associated patient or if the patient does experience this, you can use a spacer device, as the reader said. So a spacer device can reduce the risk of thrush. Okay. Mr. Joshua has just started on digoxin. Which of the following is not a side effect of digoxin? Okay, 70% of you answered so far. The correct answer is D, because it can decrease the appetite. Decreasing the appetite is a rare side effect. I wouldn't expect you to know that from the top of your head, but I would expect you to have an understanding that digoxin can cause vision disorders and can cause arrhythmias. Often it can cause diarrhea, and it can also cause skin reactions. So sometimes the question itself, you'll be confident of the other options, and that would lead you to the most likely option being the one that's doubtful. And D is probably the one that was doubtful for you because you are more confident in the other options. Mrs. Doris brings in a prescription for pethidine hydrochloride. In 2001, drugs that are controlled are divided into 5 schedules. Which schedule does pethidine belong to? Okay, let's share the answer. The correct answer is Schedule 2. Here, there's no rationale behind, as in, it's a Schedule 2 control drug. There's a lot of risks concerning pethidine abuse. Can someone name some of the side effects associated with pethidine? One of the most notable concerns is the risk of respiratory depression, and also dependency. The respiratory depression is and dependency are the most common concerns, and the most, not the most common concerns, the most severe concerns. A common side effect is, as Adam said, it can cause constipation. Mr. Andrews is a 67-year-old patient admitted due to a fall. The medical team believe it's due to a newly started medication. Which medication is likely to have caused the fall? Okay. The again, it can be tough. It can be a tough question. Um, but when it comes to likelihoods, the most likely is the bisoprolol, causing the hypotension. Particularly canagliflozin, if it's given as monotherapy, there's there's a risk of hypoglycemia, but the risk is far it is much more unlikely than the bisoprolol. So this is a perfect example of a single best answer question where there's two possible answers, but one is more likely than the other. Um, okay, so Mr. Patel is started on a new medication for type 2 diabetes mellitus, and it exerts its effects by decreasing gluconeogenesis and increasing peripheral utilization of glucose. Which of the following is he most likely to have been prescribed? Yeah, back to someone asked a question, how do you know it's more likely? Back to the what I said, it's rare for hypoglycemia to occur associated with the canagliflozin, and therefore it's more likely the patient could experience hypotension because hypotension is much more common, particularly when someone's newly starting bisoprolol. Okay, let's share the results. So the correct answer is metformin. Metformin works by mainly doing two things. It decreases gluconeogenesis. What is gluconeogenesis? I'm going to break down the term for you. So the gluco, of course, is process by which more glucose. Yes. So let's go through that in a bit more detail. So if you break it down, gluco refers to glucose. Neo is Latin for new, and genesis is formation. So it's the formation of new glucose, and in particular, it's from non-carbohydrate sources, as Ola has just mentioned. So the formation of new glucose via non-carbohydrate sources it essentially decreases this formation and therefore prevents the formation of new glucose via this route, and also makes sure that there's the utilization of the glucose that's already there. So by ensuring more glucose is utilized, it battles the problem of insulin resistance. So makes sure that more glucose is utilized and therefore lowers blood glucose levels with patients. Okay, so let's see how everyone did. So how many questions did you get right? Okay, so we've got a bit of a mix, but the majority of you got six right, which is really good to see. But anything from four upwards at this stage is a good indication that you're on the right track. Again, we're fairly early when it comes to quiz nights, but we're going to have much more quiz nights we're going to have monthly quiz nights essentially.